This is a video on fall risk. I'll be talking about the screening for fall risk, the assessment, and the interventions necessary to identify patients that are at risk for falling. This is the CDC's recommendations, so most of this content is from the CDC. So first, you want to screen older people for falls risk. Usually the guideline is 65 and older, or anybody that's had a fall in the past. For patients that are 65 and older, you can screen them annually. And if you have any suspicions that a patient might be at risk for falling, you can just run this screen just to make sure. There's a couple screening tools. The CDC has this 12-question questionnaire. I'm showing that right here on the right. And it's essentially 12 questions. The patient can look at it, read it. You can read it with them, and they can say if they agree or relate or answer yes to any of these prompts. So the 12 questions are: I have fallen in the past year, I have or have been advised to use a cane or a walker to get around safely, and these first two are worth 2 points each, whereas the other 10 are worth 1 point each. Third one is: sometimes I feel unsteady when I'm walking. I steady myself by holding onto furniture when walking at home. I'm worried about falling. I need to push with my hands to stand up from a chair. I have some trouble stepping up to the curb. I often have to rush to the toilet. I have lost some feeling in my feet. I take medicine that sometimes makes me lightheaded or more tired than usual. I take medicine to help me sleep or improve my mood, and I often feel sad or depressed. So if they get a score of 4 or more by taking this questionnaire, and again, the first two are worth 2 points, and the other 10 are worth 1 point each, then yes, this patient is at risk, and you should proceed with the assessment that I'll talk about. Another faster questionnaire are these 3 key questions. Do you feel unsteady when standing or walking? Do you worry about falling? And have you fallen in the past year? And if the patient has fallen in the past year, you should ask, how did it happen? How many times have you fallen in the past year? And were you injured during that fall? In any case, those are your 2 screening questionnaires. And if the patient is determined to not be at risk, then you can prevent future risk by recommending these strategies. You can educate the patient on fall prevention. You can assess their vitamin D intake. You can do a blood test, see if they're vitamin D deficient, and if so, you can recommend daily vitamin D supplements, usually for a mild deficiency of vitamin D levels between 20 and 30 on a blood test, which is just below normal. You can recommend 1,000 international units of vitamin D supplement. If the patient has much lower vitamin D, for instance, if they have 10 to 20 on the blood test, you can recommend 2,000 international units of vitamin D, which is pretty easy to find over the counter. If the patient is even lower, less than 10 on a blood test, you might recommend 5,000 units of vitamin D for a few months to kind of get them to catch up before switching to 1,000 or 2,000 a day. So that's something you want to keep an eye on. Vitamin D is important because it helps with the absorption of calcium. So helps some other things as well, but yeah, it prevents future risk for these patients. You can also refer these patients to community exercises or fall prevention programs. You can just generally endorse any kind of strengthening or yoga or Pilates that might help them. And you might want to reassess them next year, especially if they're older patients. Now, if you take one of these screening tests and get a 4 points or more for this one, or if they answer yes to any of these questions, you then want to assess the patient's modifiable risk factors and fall history. So there's a bunch of these risk factors, and then there's something you can do. There's an intervention for each of them. So we'll be talking about that list right here. First, you want to evaluate the patient's gait, strength, and balance. There are a couple tests you can do for this. This is usually during the physical exam portion of the encounter. So one possible assessment is the timed up and go. This is also data from the CDC, but what they suggest to do here is to have the patient sitting in a chair stand up from the chair when you say go, to walk a few meters, so like 3 meters or maybe 10 feet away. This is usually just across the exam room in a clinic, and then to walk to a line on the floor, and then to turn around at their normal pace and to sit down again. Now, if the patient were to do this in pretty fast time, in less than 12 seconds or so, then they would kind of pass this test and they would not be at risk for falling. Now, if there's an older adult who is struggling to get up or who is unsteady upon walking or who takes longer than 12 seconds, then they are at high risk and you want to kind of start one of these interventions. The other assessments are the 30-second chair stand. In this test, you have a patient sit down with their arms crossed across their chest, and you have them stand up without using their arms and sit back down as many times as they can in 30 seconds. Now, these are the average scores for men and women in these age ranges, and if they get below these average scores, that indicates a risk for falls. So that would be a concerning test result. So you might want to proceed again with these interventions. The third test listed here is the 4-stage balance test. That's essentially having these patients stand in each of these positions, each of these 4 positions. Ask them to stand like that for 10 seconds. And if they're unable to do it, that would also be a concerning gait, strength, and balance test. So here they're just standing normally. Here they're standing with one foot kind of placed right next to the other. Here they're standing with their feet in tandem, as if they're walking on a balance beam. And in the last one, their foot is only one foot is on the ground. They're standing on one foot. And they should be able to do each of these for 10 seconds. Now, if they fail one of these tests, you proceed with one of these recommendations. You can refer for physical therapy, and you can also refer to evidence-based exercise or fall prevention program. So this, again, can be a Pilates. It could be like a Tai Chi, as listed here. It could be even recommending some YouTube videos for strength-based training or for some balance exercises that the patient can do at home or can do under the supervision of a loved one. Next, you want to kind of assess the patient's medications for fall risk. There's this Beers criteria, which is a list of medications published, I think, a few years ago. And it's a pretty long paper, but they have a long list of medications. I've kind of put it in small print here. And not all of the medications are completely contraindicated, but a lot of them require some thought. A lot of them require the provider to go in, look at how much they need that medication, if it can be swapped for anything else, and if the patient really is at risk because of that medication. Some of them are kind of general drugs you don't want to give to elderly people who are at risk for falls. This includes like antihistamines, like Benadryl, for instance, or benzos. You don't want to give older people benzodiazepines. Some others might still be appropriate depending on the patient's individual condition. So don't take this list of medications as a list of banned drugs for old people. Instead, think of the patient more holistically and assess whether they need that medication, if they can replace it for something else. And that's exactly what this recommendation says. So optimize their medications by stopping or switching or reducing the medications that increase their fall risk. And again, that's a list from the Beers criteria publication from, I think, 2019. Next, you can kind of ask for a history of their home and see if they have any hazards at home. Commonly cited ones are throw rugs that might kind of slide across a wooden floor or a tile floor, or a slippery tub floor. Oftentimes patients, as they get older, might need a handle to kind of lay down into the tub or to sit down into the tub, and they might need a handle to get up and down from the toilet. If they do have that kind of problem, you might want to refer them to occupational therapy, who might be able to go evaluate their home for safety. Next, you can also measure the patient's orthostatic blood pressure. So this is essentially taking their blood pressure while lying down, while sitting, and while standing. And if there's a significant difference, such as 20 millimeters mercury in the systolic blood pressure, then that would be a significant change in orthostatic blood pressure. If that's the case, you do want to stop, switch, or reduce the doses of medications that increase their fall risk. Some medications might change their blood pressures, and you might want to kind of change your goal for the patient's blood pressure to make sure they don't have a fall associated with being lightheaded upon standing. There's some other things you can do as well. You can make sure that they're hydrated. Dehydration will kind of worsen orthostatic hypotension. You can educate the patient about foot pumps and how those exercises might help relieve their orthostatic hypotension. You can also tell them about compression stockings. These are very, very tight socks that they can wear that helps the body squeeze their fluids up to their head to relieve orthostatic hypotension. You also want to screen these patients for their visual acuity. You can just use the Snellen chart for this. This is the chart that has a big E at the top that's in every primary care clinic. If they have a visual impairment, you do want to refer them to an optometrist or an ophthalmologist. You might want to stop medicines that are affecting their vision, like anticholinergics. You can also consider cataract surgery in some patients that qualify. This can help with their visual acuity, and you can kind of educate them on the depth perception, on if they need a single or a multifocal lens. It's also worth assessing the patient's feet and their footwear. Some patients don't have shoes that have proper fit or proper traction. They might not be any tread at all on their shoes, and that of course can be a risk for slipping, which then leads to a fall. You might want to assess their insoles and their heel height, and this is something a podiatrist can do as well, so they might be able to help with that. We already talked about vitamin D, but you do want to assess their vitamin D intake. This is typically a blood test, and if their vitamin D is low, you can recommend a daily vitamin D supplement. And of course, there are other comorbidities that put patients at risk for falls. So depression is a significant one, and osteoporosis is another. So once you document these comorbidities, you can then optimize your treatment of each of them. An older person might need an SSRI, for example, or they might need a bisphosphonate for their osteoporosis, or they might need further screening that is prompted by this initial screening. Once you've assessed all of these things and intervened appropriately, you then want to follow up with the patient in 1 to 3 months, make sure that everything is going well, that they're being safe. And for all other patients that didn't need this assessment or this intervention, you can screen them again next year. So this has been a video on fall risk and how to prevent falls in older populations. I hope it was helpful, and thank you for listening.